Can everyone see the slides okay? My screen?
Yes.
Okay, great. Good afternoon, ladies and gentlemen. Thank you for tuning in to another Risk Institute online session. Today, we're especially fortunate to have with us Professor Charles Manski, an economist at Northwestern University, who will talk to us about his program of research recently published in the book, Patient Care Under Uncertainty. The presentation will be around 45 minutes with 20 to 30 minutes for Q&A. Please do make sure your mics are muted and leave any questions either in the chat or virtually raise your hand once the session is over, and I'll select them on behalf of Professor Manski. So just a little bit about Professor Manski. Charles Manski has been on the Board of Trustees Professors in Economics at Northwestern University since 1997, after researching at University of Wisconsin-Madison, the Hebrew University of Jerusalem, and Carnegie Mellon University. He received his BSc and PhD in economics from MIT in 1970 and 1973. And Manski's research spans econometrics, judgment and decision, and analysis of public policy. He is author of many books, including Patient Care Under Uncertainty, Public Policy in an Uncertain World, and Identification of Prediction and Decision. He has served as director of the Institute for Research on Poverty, chair of the Board of Overseers of the Panel Study of Income Dynamics, and he's also the editor of the Journal of Human Resources and Econometric Society monograph series. That's just a broad brushstroke of some of his accomplishments, but really there's many more that I can't cover in the short time frame. But let's offer a warm welcome to Professor Manski. If you'd like to start sharing the slides.
Okay, thanks, Francis. While I'm getting my share screen up here, just say a couple of things. Let me. Are you seeing the slides now? Yeah.
Yeah, absolutely fine.
Okay. Let me just. I wish I were able to be with you in person. I have a habit of long-standing habit of going to Britain a couple of times a year, and this past year has been the only time I've missed because of the pandemic, probably in the last 25 years. I have a kind of long-standing relationship with the UCL, with CMAP, the Center for Econometrics and Measurement there. And actually, at the very beginning of the pandemic in March 2020, I was on an annual trip, and my wife was with me. So we were in London, and if you can recall what it was like at the beginning of March 2020, when people were thinking about uncertainty, what people were learning about COVID. And we were there that week with no social distancing, no masking, no nothing. And then I was scheduled, and I made it actually to go up to Glasgow and give lectures there for a week. And middle of March, getting back to the United States was a little bit tricky, let's say. But we got back, and so here we are doing Zoom since then. The other thing I'll mention, just by the way, is although I'm in England quite a lot, I think I've never been to Liverpool, although my wife says I have. What I mean by that is that literally 50 years ago, in the summer of 1971, actually just a little bit before we were married, we traveled from London to somewhere on the West Coast and took an overnight ferry to Dublin. And she says we took it from Liverpool. I thought we took it from somewhere south, maybe from Holyhead. I'm not sure, but I hope someday it'll be possible to actually see you all in person. Okay, so we have this. This is a cover of the book. Came out a couple of years ago. The book synthesizes, exposits work that I've been doing over the past 10 or 12 years. And I had given the, this is just a 45-minute talk. I had two choices. One is to pick out one topic among the many I've been researching and then dig into that. The other possibility was to give a kind of broad overview. I've decided to give the broad overview. That's necessarily going to be superficial. But I thought, looking at what goes on at your institute, I know that there's a very wide mix of people, and if I were to choose one technical topic, it might be interesting to a few people and not to the rest. So, so I'm going to give the kind of broad sense of what I'm doing, and with lots of references to published papers and so on, as well as the book. And then hopefully we can, maybe I'm obviously happy to email afterwards to talk with people after this to dig into things further. So let me begin with this is one of the what I'm absolutely, you have an institute on decision risk and uncertainty, so I presume you're very familiar with the distinctions I'm going to make. But sometimes I find people don't segment things in the way I think is helpful, but most decision analysts do, is to distinguish three broad branches of decision analysis: normative, descriptive, and prescriptive. And normative analysis, in some sense, seeks to establish ideal properties of decision making. So all of axiomatic decision theory is kind of normative. I'm not going to be doing that at all. I'm not an axiomatic decision analyst whatsoever. Descriptive analysis is empirical work, trying to understand and predict how actual decision makers behave. And third category is prescriptive analysis, which seeks to improve the performance of actual decision making. And these distinctions are not original to me, of course. The same distinctions I've seen in the literature, at least dating back to the 1980s. So prescriptive analysis is what I'm going to be talking about. And it's sort of in between normative and descriptive, because you have to have some kind of normative thinking to define what we mean by improved decision making. And then, of course, we want to improve decision making relative to a realistic base. So that requires thinking empirically to some extent about how actual decisions are made. So this is what I've been doing. And this particular line of work is prescriptive analysis to improve patient care. Now, of course, one can be thinking about this, in any area. As I'm talking, I'm going to mention other things. So I think very broadly about public policy under uncertainty. I have another kind of expository book called Public Policy in an Uncertain World from 2013, and I've studied all kinds of policy problems under uncertainty. Most recently, I'll just mention, by the way, because I know you are people who are interested in this, is that with a couple of other people, I've got into climate change policy under uncertainty. And so we have a recent article in the Proceedings of the National Academy of Sciences on that, actually on minimax-regret climate change policy. Now, the word uncertainty, I'm going to use the word uncertainty, but I'm going to use it in a very broad term. I'm not going to actually necessarily, or even most of the time, assume that people have full probability distributions, either objective or subjective, when they make decisions. I typically, I saw Thomas Augustin on this, so you recognize this immediately. Almost everything I do is in the realm of imprecise probabilities rather than precise probabilities. So if you're thinking in a medical context, a patient might ask a doctor, what's the chance I'll develop some disease in the next 5 years? What's the chance that some treatment will cure me? You can go to the risk assessment literature in medicine and get precise probabilities for, I'll give some examples for questions like that. But actually, more realistically, you might want to give a range or an interval. So a more credible response might be something like 20 to 40%, or at least 50%, or whatever it may be. I'm just going to use the broad word uncertainty. Of course, there are literature uses, other terms. The physical science literature, if you go to the climate literature, they will talk about deep uncertainty is the term they use. Coming from economics, I tend to use ambiguity, Ellsberg's term from 1961. The macroeconomists, of course, talk about Knightian uncertainty and so on. But there are a variety of terms that are used, but it's all situations in which you do not have a full probability distribution. Now, let me make this somewhat concrete in the medical context. I've focused on a variety of very specific medical decision problems, but a lot of them fall into this very simple binary choice categorization between surveillance and aggressive treatment. And I find it it's a very important class of medical problems, but also a fairly a simple one that's good for illustration. So let's give a couple of examples. a choice between surveillance and aggressive treatment. Let's say a patient has some localized cancer, a tumor has been removed at some site, but you're worried about metastasis. Well, what would be surveillance? Obviously, surveillance would be periodic doctors with the visits with the doctor and scans, CT scans, MRIs, and maybe ultrasound scans and so on. Then they're non-invasive, they're not too expensive, and so you call that surveillance. Aggressive treatment would be, taking real action to prevent metastasis, and that would be like chemotherapy or immunotherapy. And there's a very interesting tension between those two, very different advantages and disadvantages. Aggressive treatment maybe, is going to reduce the risk of disease development, hopefully, or reduce the severity of disease that does develop if you actually, if it's chemotherapy or whatever, radiation or whatever succeeds. But of course, it's invasive, and it may have bad side effects, and it may be very costly. So there's a very interesting tension in benefits and costs between surveillance and aggressive treatment. And it's a decision that clinicians make day after day in actual practice in almost every medical specialty. Okay, now how did I get into this? So I have zero formal training in medicine. Not only no formal training in medicine, even in high school, my high school did not offer biology. So I had physics and chemistry courses, but I never had a biology course, never mind medical training. But nevertheless, I think without any arrogance or anything, that I think methodologists like myself, I'm an econometrician, or people who are biostatisticians and so on, people like us can, and decision analysts, more generally, I think we can all make contributions to medicine as long as we're careful and learn enough about the substance of the topics that we don't say stupid things about actual medical biological phenomena, because our background is in methodology, and that lies within the expertise of econometricians, statisticians, and decision analysts. And there's a particular problem that is just ubiquitous. Arises absolutely everywhere, and it's in our domain. It's not the way clinicians are trained, it's the way that we're trained. And that is that we want to do a prediction of patient outcomes conditional on patient attributes. And we'd like to do that in as refined a way as possible. So we talk about personalized risk assessment, or we talk about, we want to learn treatment response, and we want conditioning on as many patient characteristics as you can. And we typically formalize these predictions as conditional probability distributions. So what I write is development of methodology for probabilistic conditional prediction has long been a core concern of statistics and econometrics, and it's maybe the core concern of applied work dating back to let's say the 1870s, because for me, this is regression. It's just standard regression analysis. So if we go back to Galton in London in the 1870s, and the kind of modern invention of regression, that's what regression is all about, is predicting some outcome conditional on observed covariates or attributes. So in teaching, I use the term regression. I have to be very careful, though, because if you go across disciplines, you find different terms. The two terms I have at the bottom of the slide next to it, actuarial prediction and statistical prediction, those actually were used in the psychology literature back in the 1940s. There was a empirical psychology literature on how well do people predict outcomes in risky situations. Those are the terms they used. Now, if we move to today, then the term that has become very, very widespread is out of computer science is machine learning. And I find this, I could spend the whole rest of my talk, but I will not do this, ranting about how upset I am about how people don't understand that machine learning is just standard conditional prediction or regression. Another term that's used mostly in business schools is predictive analytics. And then there was this catch-all term that is, again, I could start ranting on this, is of AI or artificial intelligence, that people just throw around all over the place without being very specific about what they mean. So I just want to lay out these different terminologies, because depending on your backgrounds, you may use different ones. I tend to, these days, I just say conditional prediction of some outcome Y, conditional on some observed covariance X, as kind of the most cleanest description without any branding of terminology. Now, what are the issues? If you want to predict Y given X, like predicted patient outcome, conditional on treatment or conditional on other patient characteristics, what are the inferential problems? So this is my original background in econometrics. So econometrics has, for a very long time, beginning in the 1930s, the beginning of the field, found it very important to separate problems of statistical imprecision and identification problems. So statistical theory, and here when I talk about statistical theory, because I know there's maybe a broad mix among you people, I'm going to be talking here now about frequentist classical statistical theory, not Bayesian, but it could be Bayesian if you want. But what you want to do either way is you want to characterize the inferences that can be drawn about a study population by observing a sample. So statistical theory is all about kind of trying to formalize induction from samples to populations in well-defined mathematical ways. Well, what's identification problems? Identification, which has always been the bedrock of econometrics, is a study in inferential difficulties that persist when sample size grows without bounds. So if you just go out and assume you don't just have a sample, you know everything that's observable about a particular population, but still what's observable may not be everything that you want to learn. So then you face identification problems. These are problems that do not disappear as sample size goes to infinity. In medical research and many other areas, a classic identification problem arises from the unobservability of counterfactual treatment outcomes. If there's two treatments, treatment A and treatment B, then, and they're mutually exclusive as we generally define them, then you might be able to observe what happens to a person who receives treatment A, but then that person did not receive treatment B. It's a counterfactual, so that's inherently, it's a missing data problem, but it's inherently a missing data problem. There's no way to observe what would happen in treatment B. And by the way, that arises in analysis of randomized experiments as well as in analysis of observational data. I'll come back to that a little bit later today. Then a separate identification problem is what in medicine in many areas is called external validity. I tend to favor the older term, which is simply extrapolation, is that you observe what happens in some study population and you want to extrapolate to the kind of patients you're actually going to take care of. Many people, I sometimes use the term myself now, call external validity, but it's just old-fashioned extrapolation. That's an identification problem. Getting a larger sample size doesn't do anything to help you extrapolate from the study population. Third broad class of identification problems on more day-to-day mundane problems of imperfect data quality. Missing data because just some people don't respond to survey questions, or some lab tests were not taken in a medical context, or so on. Surrogate outcomes, that's a medical term, and we might call proxies in economics. There are a variety of terms for the same thing. Surrogate outcomes means you really want to measure some long-term patient outcome, like how long they live or something like that, but you only get to observe them for 3 or 5 years, say, so you can only observe some short-term outcomes. So you may take all kinds of outcome measurements that are observable in a short time frame rather than the outcome you really care about, which might be long-term survival. And then another classical identification problem is measurement errors of various types. Again, taking a larger sample size does nothing to help you deal with measurement errors. The econometrics literature, by the way, on identification problems began in 1934 with Ragnar Frisch in Norway, studying the classical errors and variables problem in linear regression. And that's an identification problem. He didn't use the identification problem back in 1934, but that's what it is. In my own work, it's mainly, but not entirely, on identification problems. More recently, I'm just mentioning all kinds of things very briefly because I know I don't have time to get into them. Very briefly, I've actually been doing finite sample statistical problems, but in a way very different from classical statistics, which does confidence intervals and hypothesis tests and so on. I've, over the past 20 years, if you go look at my CV, you'll see it's increasingly applications of statistical decision theory as laid out by Abraham Wald in the 1940s. And I would, again, love to give a full talk on applications of statistical decision theory to medical applications but won't do that at all here today. Excuse me. In the realm of identification, there is, to me, a very important distinction between partial and point identification. The classical econometrics literature on identification, if you go, let's say, before 1990, it will say a parameter of interest is either identified or not identified. And what that means, if it's identified, then you can learn it perfectly if you have population level data, or asymptotically, if you have let sample size go to infinity. You can either learn it perfectly or you can not learn anything at all about it. About 30 years ago, a little more than 30 years ago, I began to really question why we were viewing identification as an all or nothing decision. Either you can learn something exactly or not learn it at all. It would seem, just as a mathematical matter, of course, what you can learn about anything depends on the data that are available and the assumptions that you're willing to maintain. Okay, so this is like the most basic thing. The logic of inference of any empirical work is that you combine data with assumptions. You cannot learn anything from data alone, nothing interesting at least. You always have to combine data with assumptions, and it's the combination of the two that that determines what it is that you can learn. Now, for my entire career, I've worried about making inference with overly strong assumptions so that you can get mathematical results, but you don't believe them. So the question of the credibility of the results that you can get. And so I started thinking about doing inference under weaker assumptions. And this literally goes back 32, 33 years, a long time ago. And eventually started writing papers where the results would be bounds on parameters of interest or confining them more abstractly to some sets rather than point estimates. And so that became known, it's an old term actually, but it hadn't been widely used. But I had sort of adopted it as my term, as a partial identification as opposed to point identification. And then the question is, and so this is all on on measurement of uncertainty. Then the question that arises is, well, if you're in a situation like that, then how does it affect decision making? So I raised this question on the slide: how might one choose between treatment A and B when one cannot credibly identify the sign of an average treatment effect? And that's the question I had. The first paper I wrote on this is in 1990. Okay, so it's quite a long time ago, and there's been enormous expansion of this kind of work since then. Very important, very fundamental point from a decision-making perspective is that if you want to choose between treatment A and B, and let's say you want to maximize average welfare or something like that, so you care about the average treatment effect, but you can't learn whether it's positive or negative, the average treatment effect, there is no optimal way to choose. Because if you look at this in a standard decision theoretic way, when you think about states of nature, there are some states of nature in which treatment A is better than B, and there's some states of nature in which B is better than A. So there is no uniquely optimal way to choose, but there are a variety of reasonable ways depending upon how you go. So let me just say right now, because unfortunately, I just don't have the time, and I know I'm not going to be able to come back to it at all, is that what do we mean by reasonable ways? Well, you got to want to be precise about that. One way of thinking about a reasonable way to make a decision is standard Bayesian decision making, where you put a full subjective probability distribution down on whatever it is you don't know, and then you maximize subjective expected utility. So that's in some sense the classical way of dealing with this problem. The whole literature on ambiguity says, well, wait a minute, what if we can't do that? What if we can't put a full subjective distribution down on things? That's what I feel most comfortable with, and that's why, to me, the Ellsberg paper in '61 was such a revelation. Of course, I didn't. So in '61, I was in well before college even. I didn't learn about Ellsberg's paper until the 1980s, when a lot of other people became aware of it. So then you have a variety of ways. So you have lots of different ways to proceed when you can only make reasonable decisions. Abraham Wald focused on minimax decisions. In my own work, I do a little bit of minimax work. I primarily use the minimax-regret criterion. I talked at some length about why I like minimax-regret. Of course, there's also Hurwitz. These are classical criteria. Hurwitz is alpha minimax, and then more recent things like smooth ambiguity methods and so on that some of you may be aware of. So those are all different reasonable ways to make decisions. Okay, what have I done? It's a whole bunch of different things. I'm going to go through, I got 2 slides with the references here. I think Francis is going to post a slide so you can have all these after the talk. First paper 20 years ago was on a missing data problem in randomized experiments, paper in Journal of American Statistical Association. But I really got going in the last decade, starting 2009, on diversified treatment under ambiguity. Again, since I don't know all your backgrounds, some of you may know that diversification shows up as a reasonable thing to do in various situations under ambiguity. I have a particular take on that from 2009. That's not particularly medicine, although I talk briefly about medical applications there. What really got into medicine is based on 2010 on vaccination with partial knowledge of external effectiveness. I've written subsequent 2 other papers on vaccination. Where does the ambiguity, the uncertainty come from then? Is that, and this, with COVID, I think everyone is well aware of this, is that we really don't know much about disease transmission. And if you think about randomized trials, of course, with the COVID vaccines, whether it's the Pfizer or the AstraZeneca or whatever it may be, there were randomized trials, but it's very important to understand what was learned and not used by those randomized trials. You learned in the effect of vaccination on the patient who's vaccinated. So if some patients got a vaccine and some got a placebo, then you get the different disease outcomes for the patients who are vaccinated. The randomized trials for COVID vaccines and for any other vaccines, they basically tell you nothing about social transmission, about the degree to which vaccinating one person limits transmission to other people. That problem had always interested to me. I spent a lot of time looking at epidemiology literature to try to predict the outcomes of vaccination programs. To me, it was a problem of decision-making or policy-making under ambiguity, so I wrote this paper. Then another one is that I've subsequently done a whole series of papers on is diagnostic testing and treatment under ambiguity. So before actually making a treatment decision, I think all of you know, a clinician may do various kinds of diagnostic tests, simple ones like blood testing, urine tests or scans, or more invasive ones like biopsies and so on. And that's an information gathering exercise. Doing a diagnostic test does not treat a person, but it provides information. And so we begin to have a dynamic decision problem here. So it's more complex than a static problem of first, eventually I'm going to make a treatment decision, but should I do a diagnostic test first? If you're operating in a standard world with full probability distributions, this is a dynamic programming problem. And in the medical literature from back in the late 80s on, you can find dynamic programming analyses of this question of 2-stage diagnostic testing and treatment. I didn't want to do it that way because I didn't want to assume full probability distributions. So I was very concerned about partial identification because of the nature of the empirical data that's available for studying diagnostic testing. So I did kind of diagnostic testing and treatment under ambiguity. Going on, there's a whole sequence of papers, mostly with Alex Tetinoff, who used to be at Bristol, not too far from you, but is now in Geneva, on choosing sample size in randomized trials. The classical way of choosing sample size in randomized trials is by statistical power calculations coming out of hypothesis testing. I think that's crazy. It's not just me. There's a long history, particularly among Bayesian biostatisticians, who've argued for, I think very cogently, for decades, that medical practice should get away from hypothesis testing and they would prefer them to use Bayesian statistical decision theory to choose sample size in randomized trials, and then of course to make decisions. Again, I approach this, or together with Alex, we approach this as a finite sample minimax-regret decision making to choose sample size. Then we have a paper that I hope maybe I'll get a chance to talk about this, maybe not, because I'm giving this broad background, so I know I really can't get into anything in detail. Credible and ecological inference in medical decisions through personalized risk assessment. What the issue is there, so I'll just mention here in case, as I may not even get to it, is that we have something called clinical practice guidelines, which I will talk about a bit in the time I have. And then and they basically say, what should doctors do in this situation or that situation? But in formulating clinical practice guidelines, you can only condition on a small set of attributes. The doctor in clinical practice will observe a lot more about the patient than the clinical practice guidelines will condition on. So there gets to be a very delicate problem decision making for a clinician. There's a classical identification problem called the ecological inference problem, and this paper deals with that. Okay, that's about. Then we have the book and a couple of other papers there. There's a down at the bottom here, I've got this. This is the first time I actually collaborated with someone who's really in medicine. This paper on predicting kidney transplant outcomes with partial knowledge of HLA mismatch. That's the hard question of genetic mismatch in doing kidney transplants. So this is a risk assessment problem. So I did this jointly with an immunologist here at Northwestern. And then a subsequent paper on diagnostic testing and treatment. This is a tuberculosis diagnosis, treatment under uncertainty. And that's all 2019. And there's been kind of a flood of papers recently. When the pandemic took place, there's this paper on meta-analysis, which I will just pass over, but I started doing COVID research like lots of other people did, sitting at home and you're trying to do something useful. So I've written a whole string of paper on various problems regarding COVID. This is a very general paper here, forming COVID policy under uncertainty, which I did for a benefit cost analysis journal. It was an invited paper. And then I talked earlier about the, how would you set sample size and analyze the results of randomized trials using statistical decision theory rather than classical statistics. So that's this paper that came out just a few months ago with Alex Tetenoff on statistical decision properties of imprecise trials assessing COVID-19 drugs. This paper here is about assessing the accuracy diagnostic tests and some difficult identification problems come there as an application to COVID antibody tests. And then this paper here was the first one I did right at the beginning of the pandemic on estimating the COVID-19 infection rate, anatomy of an inference problem with Francesco Molinari. The partial identification problem there is very, very simple, straightforward, but very tough. I think all of you are aware that it's been very hard to actually know what the infection rate from COVID has been because not everyone is tested. And not only is not everyone tested, but the testing that takes place is very non-random. It's very selective, particularly at the beginning of the pandemic when the materials for doing testing were really unavailable. You had to be really sick to get COVID tests. I know this well because I mentioned at the beginning that I was in London and Glasgow with my wife at the beginning of the pandemic. We came back on, this is in retrospect, so lucky we're alive. We came back on March 16th in a totally full flight from Edinburgh to Newark, which was the epicenter in New York, in America at that time, and then on to Chicago. And a couple of weeks later, we both started to feel pretty sick. And I'm pretty certain that we both had COVID, and my wife actually spent a night at the hospital after having to go to the ER. But we couldn't get tested. You could only get tested if you were really about to die at that point in the United States. So it turned out there's a very hard problem, just a missing data problem. We don't know how many people have had COVID. It could be 3 times, 5 times, 10 times what the official rate has been. So we developed bounds based on partial identification analysis of the COVID infection rate. And then there's this final paper here, which is an expository paper for MDs, which just came out about a couple of months ago. Okay, I'm only going to talk about one piece of this work, given I said I knew. I've got like 85 pages of slides. Francis can make them all available, or you can read the whole book or everything I've ever written if you want. But I just trying to decide how I'd use the limited time I have. I decided I'd rather give this very broad brush. But I want to raise this question here because I find it absolutely fascinating of the juxtaposition of the clinical guidelines and clinical decision and judgment. And I want to talk about that, I think, particularly if I understand what you do at your institute. that maybe some of you are doing very, high-level mathematical work on decision theory. I don't know what all of you do, but I have the impression from your website that you really care about practical problems of decision-making under uncertainty. And this is a really fascinating one. So we have clinical, what are clinical, let me start with this term personalized medicine. I've already mentioned it. It means trying to condition your patient decisions on as much as you possibly know about the patient. So that's called either personalized medicine or precision medicine in the medical literature. I've already mentioned this point here, that clinicians can often personalize care to a greater degree than evidence-based risk assessments and studies of treatment response. Because if you look at the medical literature, it may present like treatment effects based conditional on sex and age and race, or obesity, or a few things like that, but not much. A clinician may observe hundreds of things about a patient, and the clinician may be able to observe much more than you can actually get if you look at empirical research in the medical literature. So I mentioned a couple of, or gave a couple of examples. Here's one. This is for prediction of risk of cardiovascular disease. You can get a risk assessment tool. This is a probabilistic prediction. It'll give you the probability of developing some kind of heart disease in the next 10 years, conditioning on these characteristics, which is fine. It conditions on a bunch of stuff. And it's based on some empirical research, but it doesn't condition on other things that a clinician could observe. A clinician could also observe obesity, job stress, exercise. That should affect the chance of heart disease as well. And so those may be relevant risk factors, but you can't get that in the risk assessment tools that are available. Another one, which is quite well known in the United States, is the breast cancer risk assessment tool for women, which will give a probability of developing breast cancer based on these attributes. Comes out of a very nice paper in 1989 by someone named Mitchell Gale and his collaborators. So it conditions on a bunch of stuff, but it doesn't condition on a bunch of other things that a clinician might know. So again, the doctor might want to make a more personalized prediction than is possible given the risk assessment tools that are available. So there are these risk assessment tools. A lot of them now are available as apps on for smartphones, where you a clinician can plug in patient attributes and get various risk assessments for different diseases, but they'll only condition on certain things and not on others that clinicians may know. Now, what would be optimal care from an economics or standard decision-making perspective? What you would do, you'd be kind of in a von Neumann Morgenstern type situation where you would be making decisions with objective risk. If you knew the actual objective risk of different illnesses, conditioning on all the information that you have available. The economics literature study this. Economists tend to call this a rational expectations setting, where you have objective knowledge of objective risk assessments, and then you want to maximize expected patient welfare. Typically, that literature would assume it's a utilitarian welfare function. So you want to maximize the chance of survival or the expected length of life or something like that. Typically, in that literature, it's assumed that the care that one patient receives does not affect other members of the population. So I call this individualistic treatment response. Don Rubin, statistician, calls this SUTVA, stable unit treatment value association. David Cox at Oxford called this non-interference way back. And of course, this assumption fails with vaccination, because then the care received by one patient does affect everybody else. And so you have that standard setup, and you can do a kind of classical analysis of patient care under uncertainty. The solution to that problem is very straightforward. With the utilitarian welfare function as these characteristics, it's optimal to differentially treat patients with different attributes if different treatments maximize the group mean welfare. Patients with the same observed attributes should be treated uniformly. You should not do anything like diversification in that classical literature. And as you observe more patient attributes, the higher you can get your maximum welfare. Now, the real world, of course, you don't have that. So what are we going to do? So what do we have in the medical literature is we have these clinical practice guidelines. So of course, medical textbooks from the beginning of modern medicine have offered, guidelines or guidance in patient care. What happened institutionally that regarding this term clinical practice guidelines, at least in the American context, I'm not sure when this started in Britain. In the American context, it dates to around 1980, when different organizations started to formally, they set up panels to come up with these clinical practice guidelines for different diseases. And by now there are thousands of them. What should be standard practice for heart disease, for 100 different types of cancer, for diabetes, and for arthritis, and on and on and on. And you can go online and find these clinical practice guidelines. Now, they're not formal mandates, they're advisory. But in some cases, they get close to formal mandates because there may be strong financial or legal incentives to comply with the guidelines. The medical literature really exhorts clinicians to adhere to guidelines, arguing that guideline developers have superior knowledge than do clinicians. In the United States, this has been pushed very hard in the medical literature, and my understanding is this is also pushed by the NHS in Britain, that clinicians, the NHS will, you should follow the guidelines according to the NHS, or NICE, or whatever the part of the NHS is putting out guidelines. Now, the interesting thing is that there's no, from the rational expectations perspective of classical economics, there should be you should not need clinical practice guidelines at all. You should have decentralized decision making should be best, and there shouldn't be any outside agency that tells you what to do, basically. So here's the other issue that shows up, and actually, given the limitation of time, I just want to raise this with you, and then I'm just going to go to the end. Is that it turns out, the economist notion of objective decision making under risk, with the rational expectations, psychologists sort of debunked that way back in the 1940s. So I'm not talking about modern psychology we might attribute to Kahneman Tversky and behavioral economics literature of the 1970s and 80s. I'm talking about a much earlier psychology literature from the 1940s. This is if you want to be interested in, it's a very nice review article on it in Science in 1989, and they did actual research, empirical research, on how well do doctors do risk assessments, do medical risk assessments probabilistically for patients. And they compared that with what you get from statistical predictions, or what they call actuarial predictions. And they found that what the doctors do on their own, basically thinking of the clinician as a subjective Bayesian, if you want to use that formalism, that they just don't do very well at all compared to what you can do with a formal statistical method. A formal statistical method in the 1940s would be if it's a binary outcome, like does a person have a disease or not, is to estimate a logit model. The logit model comes in 1944, so people would estimate a logit model. And they would find that the predictions made by logit models were better than what the doctors were doing using what we call clinical judgment in medical decision making. So, so that says, well, maybe you can't trust, what the economists have to say. Maybe you do need these guidelines because they're going to do it better. So that's what goes on in the medical literature. The guidelines, use of clinical guidelines, have become very, very. They're everywhere. Okay, now I only have a few minutes. So I really hate to do this because I love to talk about this so much, is skip through like basically all the substance, and just don't mind me for a moment. I just want to scroll through to the concluding slides. I knew I would get to this. Is go to conclusions. So so that I can give something like a coherent talk right now. So at the beginning, as I just mentioned here, I asked this question: should clinicians adhere to guidelines, or should they operate in a decentralized way and exercise their own judgment? The guidelines, they basically call for uniform treatment of observationally similar patients. And the medical literature will talk about optimal clinical guidelines. And they love, I'm an economist, so I should love the word optimal, because economists are always talking about optimization. Unfortunately, when the medical community talks about optimization, they do it totally verbally without defining really what they mean by optimization. They do not, the medical literature, to my great frustration, I found, except for occasional, I'm talking about the mainstream medical literature, what's published in the Lancet or BMJ or the New England Journal of Medicine or Journal of the American Medical Association, you will find no formal decision analysis, no math, no nothing in those journals. There are corners of the medical literature on medical decision making that's more formal, but that's very much marginalized. So they'll talk about optimality, but not define what optimality means. But what they'll say as a prescription is that observationally similar patients should be treated the same way. The issue is that they're implicitly assuming a world of certainty, or at least a world of objective risk. Because the argument, and this is what I go through formally, I developed this argument throughout the book on patient care under uncertainty, is that the argument for uniform treatment of patients weakens substantially when clinicians face real uncertainty. And so in the book and in many journal articles before that, what I argued for is diversification under uncertainty. And of course, everyone's familiar with diversification from portfolio analysis and finance. Diversification in finance and in medical treatment are mathematically exactly the same. The same framework with risk aversion, but you can also get diversification as the mathematical algorithm. So that's what I've done in my own work. So clinical practice guidelines would never say diversify; they would say treat everyone the same way. So, and there's a variety of reasons why there'll be this. You can just read what I've written here. I could go on at great length, but don't have the time. So again, a theme I've developed in my technical work is something called adaptive diversification. Start off with a static problem of diversification, and then change the fraction of people receiving treatment A and treatment B. Change as you learn more, change those fractions. So I call that adaptive diversification. Now, the final thing I'll say, and then I will stop, is that I've come to, and this has been in writing. The first time I put it into print was in this PNAS article on diagnostic testing back in 2013, is that I actually think in many cases, these organizations should stop making recommendations on treatment. There may be some cases which are very clean, where there's total consensus on what the right thing to do is in a certain case. Like if someone has strep throat, you're going to give antibiotics. There's no uncertainty about something like that. But so much of medicine has so much of an uncertainty. And as I dig in to different diseases, I've learned about kidney transplants. I've been working with a transplant surgeon at Northwestern now on cirrhosis, on liver disease, and learn about uncertainties there. And it goes on and on and on, how much uncertainty there is in medicine. And then maybe putting out clinical practice guidelines is not helpful. It may actually be harmful. So what I want to do is I want to separate two roles that these clinical practice guideline panels now play. The first role I think is great. The second one I think is problematic. The first role is to characterize medical knowledge. You need to have some kind of panel of experts try to synthesize the literature, because there's just so much. The medical literature it's so vast. There's so many papers published, it's impossible to keep up with it if you're an ordinary day-to-day clinician. So these expert panels do that. Now, there's parts of the way they do that I do not like. I very briefly mentioned meta-analysis before as a methodology for combining results across different studies. I think the way meta-analysis is done, which is generally by taking a weighted average of findings across studies, is very wrong-headed. So I have an article in the journal Epidemiology last year that makes that case strongly. To me, this is a partial identification problem. But the broad issue that these expert panels should try to characterize medical knowledge. Yeah, great. I think they should do that. The other issue is that the part that I'm concerned is they make recommendations when I think they shouldn't. And because the recommendations they may give may not be the right ones for decisions under uncertainty. I could flesh that argument out at length. I say down here, and I think this may be of interest to you in your institute, and I don't know how NHS, for example, operate. I think NHS is better about this. In the American context, there's no quantification of uncertainty at all. They actually shun use of decision theory. I could quote at length from documents of the Food and Drug Administration, which says they do not want to quantify things. They absolutely will not do benefit cost analysis in a formal way in the drug approval process. I find it fascinating that they're actually formally antagonistic to use of formal decision analysis, but that's the way it is. As I say, I've had limited contact with the NHS on one issue that I've consulted with them on, where I think they're much more open to this, but maybe not entirely. Okay. Finally, well, what can we do to this is my very last slide. What can we do to improve things? Of course, people like myself, people like yourselves who work on risk and uncertainty, I think we all have contributions we can make. This is a field with, I just think there's unlimited scope for pretty interesting research that we can do. A lot of it should be done in conjunction with MDs, the people who have the institutional knowledge, but you don't need that for all cases. But I don't think that's going to be enough, because there's a real cultural issue in the training of medical students, is that they don't learn anything. I'm talking about American medical schools that I have some knowledge of. I don't know the curricula in British medical schools, but basically they don't learn, the only thing they may learn in medical school, if anything, is if you're doing some kind of trial, is what a t-test is, or the most absolute basic cookbook aspects of hypothesis testing. That's about all they get. I think medical students, at some case, it may not be in their early medical training, but maybe in their residencies and fellowships after. Well, all of them should learn the core concepts of uncertainty. Even in the initial medical program, you should understand about uncertainty quantification and decision analysis, part of the basic education. But obviously, there's not much time there. I think the real goal would have to be to develop a medical subspecialty, a new medical specialty on medical decision making, on complex medical decision making, or medical decision making under uncertainty. But this could be, a subject for residencies and fellowships after people get their MD degrees. And to have that happen, you have to have medical schools actually create the curricula and implement these curricula. In the United States, there's almost none of this. I've heard that Tufts University in Boston has a little bit of this. That's the only case I've heard of. I don't know. In the UK, I don't know whether any of the medical schools do this. But looking ahead, I want to end on what we should do looking forward. If we try to start, I'm going to stop sharing. Collaborate with people in medical schools and try to help them to develop curricula, I think would be extremely useful. Okay, we started a little bit late, so I'm maybe only a little bit over the 45 minutes, I hope, but I will stop there.
That's absolutely fantastic. Thank you so much, Professor Manski, for sharing your work. I think it's really vital. We had a talk from Professor Gerdger Garenza not that long ago, and I think you both converge across quite similar conclusions, and he's been looking at European doctors and their education with regards to uncertainty, and it doesn't exist in Europe either, to be honest.
I've never met him. Of course, I know some of his work, but it's odd that we've never actually met.
Yeah, I think you two would have a lot in common, in fact, and a lot to discuss in this research area. So I'd like to open the floor. Does anyone have any questions for Professor Manski?
I'd like to ask a question.
Please.
My name is Julian. I'm a graduate student from Munich. Thank you very much for this very interesting overview on your work, Professor Manski. You mentioned in the last part that the expert panels in the medical domain and medical literature, like NHS and FDA, abstain from using mathematical optimization and explicit decision theoretic modeling. And I would like to understand their point of view a bit better. So what's their line of reasoning? I mean, from my perspective, I'm a statistician. It's hard to understand why not to use it. And maybe you can give some impression on what they tell you why not to use it.
Well, first thing I'll mention to you personally is that I've been working in this area with an old friend in Munich, Joachim Winter. You know Joe Winter in the economics department? Which is Helmut? No, you don't. Well, he's a full professor at Munich, and we've actually been working on with a PhD student of his, Karina Hartung, her name is, on this is empirical work, not prescriptive work, where we pose, we have actual clinicians do risk assessments and we allow them to give either precise or imprecise probabilities, where we provide them with scenarios, and then we actually make them have them make decisions. And we're trying to learn about decision making, how they do the risk assessments, whether it's precise or imprecise probabilities, and then how they make decisions. So that work's been going on for the last 2 or 3 years. So I will maybe this will. Since even though to me he's Joe, but and you know, even though I go to Germany a lot, my pronunciation is sorry, not good at all. Here is his name. I will put it into chat. Okay, so you might want to talk with him. Now on your question, you know, you're trained as a statistician and I'm trained as an economist. This is bizarre to people like us. I actually, in my book, I quoted from an FDA, this is on chapter 6, I think, or chapter 7, maybe. I quoted 2 full pages from an FDA document where they argued vehemently against the most standard kind of decision analysis, where you begin with a multi-attribute utility function. So you think that, you know, if I give treatment A, there's going to be many variety of outcomes. How long will the patient live? You know, how quality of life, how much will it cost? You know, side effects of the disease, on and on and on. And then we try to aggregate this into some welfare function and maximize that multi-attribute utility function. That's, you know, absolutely standard for decision analysts and economists. And the FDA says, and actually Congress asked them to do that in 2012, and they refused. They actually wrote, we do not want to do that because quantification of uncertainty is arbitrary and it will prevent us from making informed subjective decisions. Now, my view, and I know I'm being recorded, but I don't mind, my view is that the FDA is, they have some very good biostatisticians there, and they have economists to work there, but basically, this is something a bureaucrat would say when the bureaucrat does not want someone from the outside to look at what they're doing. What the FDA basically says is, we're the experts, we know, trust us. And if you force us to quantify anything, it will be, they actually say words that quantification will be arbitrary and make it our decision-making non-transparent, when we would think the opposite. So I you know, to me, this is not, I can't explain it on any good grounds, but this is what they do. And the FDA does it. There's a whole book-length study by the Institute of Medicine in the United States on clinical practice, trustworthy clinical practice guidelines of 2011. It talks about optimization everywhere. There is not a single equation, no mathematization, no formalization at all in all 500 pages. So the only answer I can come up with is that maybe it's a bureaucratic thing, or it's just that there's some people who, or maybe it's arrogance, they can just think this through in their head, but they can't express it for other people. I don't know, but I'm sorry I can't give you a sensible answer. This frustrates me quite a bit.
Thank you anyway. Yeah, it appears very unscientific to me, but I have no idea how the practice works, so this is just why I was confirmed with it. But thank you.
Charles, you'd suggest that there's a job preservation aspect to some of this? It's a little based, but it's a distinct possibility, right? In which case it's a scandal because we're protecting doctors, not their patients.
That could be. That could be part of it. This is not something I've ever gone public and made that accusation because I want to keep friends with the clinicians, right? Because some of them are really, I've learned that some of them are great people, and I want to do joint research with them, but it could be what you say.
I believe Alex has had his hand raised for some time as well. Would you like to unmute yourself, Alex?
Yeah, just to jump in on just that note. I don't know if it's me just being far too overly optimistic about people, but could there be an aspect of perhaps people are very, very squeamish about optimization when it comes to like balancing off the cost of a policy or a healthcare decision against someone's well-being, because that kind of implicit, you kind of necessarily have to introduce costs to get to a decision, and maybe just people are uncomfortable, maybe like because maybe they don't understand how it fits into their decision-making process, and just that makes them feel uncomfortable about applying a procedure like that. But I don't know if that's actually reflective of people's thought process in your experience.
Charles, you're
so
muted.
Yep, muted. Sorry.
Yeah, sorry.
I'm sorry. I think I don't know if my internet went down or I had to reconnect. So I missed Alex. I missed everything that you said.
Okay. So yeah, to be fair, it was just kind of a general point. I don't know if I'm just being too generous to people, but one thing that I did want to ask is we've been talking with anaesthetists from the hospital in Liverpool about the use of risk calculators when discussing the risks around like perioperative medicine. And the decision for like laparoscopic procedures, like whether or not it's safe to go ahead with a particular procedure for a patient. And there's rafts and reams of calculators, I'm sure you're aware. But something that I brought up to them that didn't seem to get that good of a response was having calculators that have like imprecise probability outputs to try and account for the fact that, as you say, like clinicians will be able to make use of all sorts of things that calculators won't all cover, because you can't, it's very, very difficult to account for all the different variables that might be relevant to a decision. Presenting the output as an interval and training the doctor to recognize that and say, okay, well, there is uncertainty, there's things that aren't taken into account. This patient now, you have a kind of a window, and your clinical decision can kind of move things within that window, and to sort of have them as goalposts that they can make a decision in between. I don't know if you've mentioned anything similar like that to anyone before, but I don't know if what you think the response to something like that would be.
Yeah, I'm glad you asked this. The work in Munich that I mentioned just a couple of minutes ago is doing that. We're actually we're allowing the clinicians to give interval probabilities for their risk assessments of cardiovascular disease.
Hmm.
And we've already tested this out on medical students, and now the work is proceeding to do this on practicing clinicians. But I've also done recently a fair amount of work eliciting imprecise probabilities from ordinary people, not clinicians. You know, they go, so this is like a whole other strand of my work, goes back 30 years. I've been eliciting subjective probability distributions from just ordinary people in household surveys a day for about 25 years now. And in Britain, this goes on with the ELSA study. People do that, the English Longitudinal Study of Aging. They do this kind of thing. Now, typically, we would do this asking just for a precise probability on a 0 to 100 scale. But I started experimenting, asking for interval probabilities. And then I have the paper that's just, it's available online. It's forthcoming in the Journal of the European Economic Association. Is on a large sample asking older people about the risk of dementia, the risk of getting Alzheimer's or other forms of dementia. And we have a format where we first allow them to ask them to give a precise probability. And then ask them, I'm sorry, I don't know what, I'm out of practice from lecturing, from sitting here all summer. Then we allow them to give interval probabilities. These are just ordinary people. And we find that over half of them, when they're given the option, they give intervals instead of precise probabilities.
Hmm.
And so this article, which is joined with Pamela Gustinelli and Francesco Molinari, it's on my webpage, or it's on the JEAA webpage already, is forthcoming. So we've done this. You know, these are with ordinary people. And I think we're hopeful that this can work. So if it can work, it's on a medical topic. It's on their own personal risk assessment of dementia. Yeah. If you can do it with patients, then it seems you should be able to do it with clinicians. But there may be heterogeneity. I would say an unfortunate thing working in this area, when I've been a patient and I've had to see a doctor myself, I'll ask them about me. What's the chance that this will happen or that will happen? And some of them will feel comfortable and others refuse. I had one person say he was cautiously optimistic that a procedure would work. And I said, well, can you quantify that? And he said, no, I won't. Now,
yeah, maybe, I mean, would you expect a clinician to give you a figure off the bat in a situation like that?
Well, it depends on the clinician. But I think they're not trained to think probabilistically. It's very odd. They see these risk calculators that you're mentioning, which are all over the place. They're all done in terms of precise probabilities.
Yeah. So
they think they understand what probability means. Of course, they don't really, because they don't know underneath what's the algorithm that formed the risk calculator. You have to go read the underlying technical articles in the journals. And unfortunately, a lot of the risk calculators are based on proprietary information, and there is no journal article that you can read. But the doctors think that they understand the output of these risk calculators, but I'm not sure how often they actually do. But I think this goes back to the final point I made in the formal lecture, formal talk, is that there needs to be some change in medical education to have clinicians feel more comfortable doing this. I think with that, I think they're perfectly capable of dealing with interval probabilities. But it has to be part of their culture to do it. Right now, it's not.
To get the training, you need to have curricula first, right? You need to have a slide series. Do you have a slide series for doctors?
In a sense, yes. I mentioned at the beginning that I was in Glasgow in March 2020. The reason I was there is I have, from the book that I've written, I've developed a short course. It's 6 lectures, totally, it's like what I was talking about to you today, without the math. There's all the math in the technical articles, but I wanted clinicians to be able to do this. And I've done this, I think, a few times, I hope with some success. So I did it in Glasgow, I did one in London, and I've done a couple in the United States. And it's something I'd be very happy to do again. And I've had very interesting mixes of people. I've had mixes of, when it's really worked best, I've had some fraction of economists, health economists, econometricians, some statisticians, biostatisticians, and some medical clinicians. And hopefully the size of the group is reasonable so people can talk. If it's 25, 30 people, they can do that. And I've done this like as 2-day workshop or short course. I think I could reframe these, within a standard medical school curriculum and do it as well. But that's, yeah. So I've got the slides and I've got the book underlying it. The book, this patient care and uncertainty, I purposefully wrote it. The entire text is totally verbal. There's some appendices or complements at the back that work out some fairly straightforward math to people who want to see it. But I wrote it on purpose, totally verbally, so in the hope that clinicians could read it. But you have to be able to break into their world. And so I've been devoting a lot of my own, increasingly over the past 10 years, of my own effort to doing that. And but I'd love for other people to join in, and to be doing this kind of thing.
Yes, definitely. I know that Thomas has also had his hand raised for a while, so would you like to chime in, Thomas?
Yeah, thank you. So I would like to come back to the point of external volatility as a reason for non-identification. I think this is a point which is also extremely important in medicine. Can you expand a little bit about this? Because I do not see how to tackle this identification problem. I think there must be a lot of model uncertainty around in the extrapolation, etc.
Yeah, well, so let me, a model uncertainty was another word for ambiguity, deep uncertainty. The underlying, okay, so let's think about clinical trials, randomized trials. And here's a kind of classical problem of extrapolation or external validity. The patients in clinical trials are not randomized. The whole methodology of randomized trials, going back to R.A. Fisher, relies very heavily on having these be on randomization, right? But who are you randomizing? You're not randomizing the general patient population. You're randomizing people who agree to participate in the trial. So you have a choice that's made, a selection of who agrees to participate in the trial. And treatment response among people who agree to participate may be different than people who don't agree. Second, even among people who are willing to participate, the experimenters will not accept everyone. Some of you may not be aware of this unless you're actually doing medical work, that they typically want patients who have no comorbidities. So comorbidities means if they have multiple things wrong. So a person may have heart disease and may have arthritis and diabetes and this and that, but they want people who only are sick with one thing, because they want what they think of as a clean estimate of the treatment effect. But of course, the people with no comorbidities in general are healthier than the other people. So we have another problem with external validity. Third problem with external validity is just doing things in different geographic areas. You can do a study in Poland or in China or in Russia, and then try to extrapolate the findings in the United States. That may be fine for some diseases, but not for the others. So there's all kinds of reasons why there's problems with extrapolation. The question is, do you have to just say, well, we don't know anything about that? Or can you put some kind of informed bound, if you will, on how different the study population is from the population of interest? So a statistician or an econometrician or a decision analyst, those of us who think abstractly, we don't have the background to do that, because you have to actually know something about the subject area. It would be crazy for me as an econometrician to try to put a bound on how different males are from females. So extrapolating from results on males to females, or from whites to blacks, or from people in Liverpool to people in Glasgow, or even, on how big those differences are. But someone who actually knows something about the substance, so you could actually do the modeling, if you will, should be able to do that. Now, I doubt that anyone is going to know enough about it to be able to do exact extrapolation, but they may be able to put an upper bound on how different is this group from that group. So I published papers that do that. The 2018 paper on ecological inference that I mentioned very briefly actually does that. It actually bounds the difference in risk of heart disease between blacks and whites, and between and various other groups. In that case, I did it as an illustration. So I made the bounds myself, even though I'm not a cardiologist. If I were doing this in the real world, I would want those bounds to come from actual clinicians. It's a kind of you could think of it in Bayesian terms as at least in terms of not putting a full probability distribution down, but at least putting a support for a distribution, right? To say that the difference between people here and people there is not greater than something. Once you can do that, then I know exactly how to do the formal analysis. Mathematically solving these things, if you go to my 2018 paper, it becomes solving a linear programming problem, and it's quite tractable. So the whole, the issue is like, where would the bounds come from, so that you can relate a study population to the population that you really care about, so that you have some credible basis for doing that. Once you do that, then it's standard partial identification analysis, and it's standard statistical decision theory as well, because Wald's statistical decision theory does not require point identification at all. I mean, Wald's theory is just beautifully broad, and it works just as well. I can do minimax-regret, and I have done it, minimax-regret with partially identified problems just as much with point identified problems. So that's that's at least in the limited time we have now.
Thank you. I totally agree, and it was certainly very helpful what you said. What I'm playing around a little bit, and I think it could also be of help here, is to do some kind of post-stratification with imprecise weights. So some people try to extrapolate from randomization to other populations by giving weights, sampling weights. And I think one could also try to have imprecise weights for post-stratification.
I have not thought of that, but that, as you say it now, it makes sense to me. Yeah, instead of having point weights, they'll generate bounds. It's yeah, sure. So you say people have done that with imprecise weights, or you're thinking about it?
Yeah, we are just we are thinking about it, yes, but we have not come far. We have the feeling, as you said, it again turns in basically a linear optimization thing. So basically, it should be doable.
Yeah, I think so. Yeah.
I also have a question which isn't related to patient healthcare, if I may. But I've been modeling the kind of finances and economics of startups using imprecise probabilities and probability bounds analysis. I was just wondering if you had any thoughts about why modeling finances hasn't been done with imprecise probability already today.
it's, I don't know much about finance. The one, I'm blanking on the names. There are some people in finance who are starting to think in terms of decisions under ambiguity, emphasize probabilities. There's a husband-wife pair at Cornell University in the United States. The woman is Maureen O'Hara, just like the actress, the film actress Maureen O'Hara. Her husband, who, sorry if I get as a problem of aging, if you will, I'm blanking on names of people who I know very well. Her husband, his name is not coming to mind, but they've done joint, this particularly after the financial crisis. There was like a spurt of work on finance under ambiguity. I even wrote a paper myself, so I do remember that, with Buzz Brock, William Brock, published in the Journal of Money, Credit, and Banking back in 2011, on David Easley. I know names, I can't figure out the psychology, the cognitive issue. David Easley is her husband at Cornell Economics. Brock and I wrote on bank regulation under ambiguity. And the issue there was on the probability of that loans would go bad. There's a probability there'd be no repayment of a loan. But then the figure is after the financial crisis in 2009, 2008, 9, 10, that the banks may have lost, they wouldn't believe their risk assessments for loans going bad anymore. So they may have been dealing with ambiguity. And so we modeled the banks as making decisions on loans using alpha max min and minimax and minimax-regret and so on. And then we actually modeled it as an equilibrium problem because the banks are competitive. So, so that was just one paper that I did myself. But I think David Easley and Maureen O'Hara, if you could find their work and then trace it through Google Scholar, you will find some work. I don't know about startups.
That's great.
But I mean,
yeah, no, thanks.
Classical finance.
Yeah, thanks. No, I'll look into that for sure. I found it quite challenging myself, but I've just finished my my model and been writing about it. Hopefully, going to send it off for publication soon. So
yeah,
thanks. Yeah, I'll definitely look into their work. Have we got any more questions from the audience?
At the risk of unleashing a torrent on this subject, what's so bad about meta-analysis? Can you say? Can you?
Oh yeah, sure.
Rant that you'd like to give?
Yeah, it's well, for those of you who aren't familiar with it, the standard methodology is that you get multiple studies done in different places with different populations and different. There may be hundreds of different variation in exactly what was done. It's really apples and oranges, and you try to figure out, well, how am I going to combine the results of the across studies? And what you do is you do a weighted average. It could be like a simple average of the findings of a study, or a weighted average. Some people will take a Bayesian, formally a Bayesian view, and put subjective probabilities on this study being right and that study being right, so they get the mean of a Bayesian posterior. But whatever it is a mean. It's a weighted average. Let me mention, since meta-analysis is very common in medicine, but not only in medicine, it's also used in climate modeling. So we discussed this. The new article that I mentioned at the beginning on ambiguity in climate modeling, they have these very complex climate forecasting models where they run on supercomputers, and each model makes different assumptions, and they put out different 100-year forecasts. And what the climate scientists do is they put out a weighted average of forecasts. That is literally what they do. Now, why shouldn't they do that? The reason why they should do that is that the formality, if you go to the history of meta-analysis, the formal work began with a very simple problem where you just have, there is no, it goes back to the external validity question we were talking about, is that there is no external validity question. If I have 10 studies done on 10 random samples from exactly the same population, then a weighted average minimizes variance. Okay, so that's a very classical statistical problem. Is that if you had 10 studies on 10 random samples and just observe the results, and I want to minimize variance, then I should do a weighted average with the weighting is by sample size, by the inverse of sample size, right? Now, the problem with meta-analysis is that although that's a very well-defined statistical problem, it began to be applied in these situations where the studies actually are not just 10 random samples from the same population. They're 10 studies from 10 very different populations, measuring different kinds of things with different people, and they still do the weighted average. A person named Nan Laird, I think she's now retired at Harvard School of Public Health, to formalize this, she developed in the 1980s a kind of random coefficients linear model where she recognized that the parameters may actually be different across models. But she decided that she was going to model this as not having like 10 random samples from the same population, but like you have 10 this is the part that gets hard to conceptualize. You have 10 studies drawn from which are a random sample of potential studies. It's as if the actual 10 studies that were done were a random sample of potential studies, and then you're going to estimate the mean parameter across these potential studies. Now, what does it mean to have a random sample of studies is just philosophically, conceptually not entirely clear. But mathematically, if you've done it, then you can estimate a random coefficients linear model. Her work has become the standard. I checked on Google Scholar. Last time I checked was a year ago. At that point, she had close to 30,000 citations on Google Scholar, just to show how, but it's wrong. It's because there is no such thing as a random. So the way I view this is basically going back to what what I was saying to Thomas about getting bounds where you have external validity issues, is that basically you would get a bound from each study, and viewing this formally in terms of a partial identification problem, the truth would have to lie in the intersection of bounds. So part of, I know, Scott, you told me you know my book on partial identification of probability distributions. So in there's this work on what we now call intersection bounds, is that you have one bound from one study, another bound from another study, but there's an estimand that you want that's going to combine the work across them. Then you get an intersection of the bounds is what you can learn by putting the studies together. The book was written in the early 2000s. By now, there's a lot more work on these intersection bounds. I think that's what should be done for meta-analysis, is to compute intersection bounds. And that's what I argue in the paper published a year ago in epidemiology. And I give us some baby examples of how to, in a medical context, of how to do that. So again, I'm sorry if I'm talking too fast on things that I've spent a lot of time thinking about, but does that somewhat answer your question?
Yeah, that's the answer I was hoping for, actually.
Yeah. So the epidemiology article, that's just the name of the journal, it's just epidemiology, is that tackles that directly.
Thanks.
Thanks. Yeah. Have we got any final questions for Professor Manski before we wrap up?
I've got one more if no one else wants to jump in. Just
go for it, Alex.
I'm putting something together that's basically trying to build like a medical diagnostic algorithm, not a computer algorithm, but like a diagnostic testing algorithm, and finding some like optimal combination or sequence of tests for identification of a particular illness. And part of like the way that's being designed is to try and make the cost functions that you're trying to optimize over explicit and more kind of transparent to the person that's using it, and making it clear to them that for you to find like what is optimal for your case, like depends on what it is that you're after, and presenting a bunch of different medical like Udin's index and PPV and things, like different things that might be useful for different situations, and kind of opening that to the user. Do you think that's a good way to try and get people to get to grips with optimization and how to use it?
It sounds like it may well be. I mean, there are concepts that you just mentioned that the medical people are familiar with, PPV and MPV, I think.
Yeah.
In the paper I wrote myself recently on diagnostic tests, Most of the time they give results on accuracy of diagnostic tests, the sensitivity and specificity. And you need to use Bayes' theorem to, I'm sure you know, to PPV and MPV are really what you care about, not sensitivity and specificity. I'm often very concerned they don't know how to do the translation through in their heads through Bayes' theorem, and it depends on prevalence, you know, on the prior and so on. But I think they do understand what PPV and MPV is. Uden's index, some of them may understand that. Not sure how well known that is. The epidemiologists, I may know it. But if you can find it in concepts like that and be able to formulate the problem in language they understand, which really requires collaboration with them. Then that seems to me a very good direction. And particularly to go through a series of diagnostic tests is much more complicated than anything I've done, which was just do it for a single diagnostic test.
Yeah, I should say it's very much a work in progress. But I think like the idea was to try and, because like if you're optimizing for if you're optimizing for PPV like against like I don't know, just monetary cost of tests or something, it's like, what does that actually translate to in terms of what that means in medicine and things? And it's speaking with clinicians and understanding what the outcomes of these tests are going to be to get an understanding of how these different metrics translate into actual medical usage.
I'll mention by the side, I'm involved right now in a project. It's kind of a classical, this is a risk assessment for like kidney biopsies after transplant to get early warning of that the transplant is degrading. And there's all kinds of stuff going on, and there's a lot of PPVs and MPVs, and we'd have these Zoom meetings. But they also use other stuff that's very much harder for me to translate into any optimization problem, particularly a lot of discussion of AUC, of area under the curve. And I can look at the math of that, but I find it quite hard to say, what would I do with AUC? But they seem to like it. And so I mean, maybe we should just continue talking some point after today, but I just try to figure out how to, and of course the weighting of PPV and MPV, right? Because it depends on your patient. I'm sure if you've been thinking about this, you know, but they don't do that formally. I've been enough on the Zoom calls with clinicians that they get these numbers and then they try to. I could be nice to them and saying they've got really good supercomputers in their heads and they're being great Bayesians, but they do all the mushing together of the numbers in their head without formalizing it. And it goes back to that issue we talked about before of the not wanting to formalize. How you could help them, you know, with some decision tools to help them be more coherent about this. I think that's great. I mean, that's why you're saying at the end there's like infinitely many possibilities for useful research to help medical practice. And it matters because we're patients too, right?
Yeah, exactly.
Yeah.
Could I interject that one way that we might help is to start shaming the people who are producing these risk calculators. You know, the ones that use pure probability, the ones that have secret or even proprietary codes. It seems to me, and we've talked about this with those anesthetists that Alex mentioned, that there ought to be a patient's bill of rights that sort of spells out, you know, what's acceptable in terms of these calculators and really what's not. Because, you know, we can go onto WebMD and find these or equivalent calculators, and they do essentially the same thing with arguably not much more sophistication, to be frank. And
well,
it's dangerous because they are using them as defensive tools.
Okay, so let me push this a little bit. I understand you're the director of the institute. Is that correct?
Well, it's a dirty job.
Yeah. Well, I want to give you something to do. I think to have something like what you're suggesting be fruitful, I think having an individual researcher take it on is not going to work. It's not going to have credibility. Right. Having an institute on risk and uncertainty take it on, you know, setting up a committee with the right mix of people, and they don't all have to be in England either. I'd be happy to to do this by Zoom, or even if we ever get to fly again, if I ever make it back to across the Atlantic. I think it's kind of a great project for an institute.
Yeah, we think so too.
So now you're upset. You're probably saying, "Oh, you shouldn't have made that suggestion," because now you'll have work to do.
No. It's the opposite. You're going to be upset when you get the invitation.
Well, the problem is I'm not going to be upset. Actually, I hope you've gathered over the last hour and a half. I've been really, this has been invigorating for me, rejuvenating for me at my age to do this work, and I find this stuff really exciting.
Cool.
So so I would not be upset to get such an invitation.
That's great to hear. Thanks.
Well, I think I can speak on behalf of the Institute that when it's possible, we would love to have you over when things are resuming in person, for sure. So thanks again for your talk, and I think the conversation's been really insightful and engaging and stimulating. So let's thank our speaker again, and if anyone would like to talk to Professor Manski afterwards, maybe on request, I can share his email address. But otherwise, hopefully stay in touch, and we'll see you again soon in person.
Okay, thank you for inviting me.
Thanks so much.
Thank you very
Thank
much.
you very much.
Great day.
See you later, everyone. Bye.
Bye-bye.